Buenos días y sean bienvenidas y sean bienvenidos.
Good morning. Welcome to the seminar on nutrition at early stages of life, implications and challenges for the region of the Americas. I'm Pablo Duran. I'm a regional advisor on perinatal health with headquarters at the Club PAHO in Montevideo, Uruguay. And from here, we welcome you to this seminar. And before going to the contents of the seminar, we wanted to share with you some technical issues that may ease the entire process to you. You'll see that at the bottom of your screen, there's an image. You have the icons. There's a globe, and that is for interpretation, and you can choose your language. This seminar is being streamed both through this channel and that of the Pan American Health Organization, and we have simultaneous translation into Spanish, English, and Portuguese. So it's up to you to choose the language that you like best, the one that you want to use to make the most of this seminar. And we hope that this seminar will be of great interest for you. So once again, I want to welcome you to this seminar in the name of the director of the director of the department, Ms. Dr. Andres de Francisco, and Dr. Susan Cerrulla, director of the Latin American Center for Perinatology, Women's and Reproductive Health. This seminar is part of a set of seminars that the center has been organizing on topics related to perinatal health. And in that respect, we thank you for your attention, your interest, and your engagement on these topics. These are very relevant topics, and we especially focus on this because COVID-19 adds new complexities, but at the same time, it has given us a possibility to connect remotely to analyze these aspects that are extremely important. The seminar represents an effort coordinated by Family Promotion, Live Course, and Club. It was designed with the active intervention of colleagues, both from the Pan American Health Organization, very specifically the Nutrition Unit, and one of the collaborating centers of the Pan American Health Organization. And in this work that has included many stakeholders and departments, we're going to analyze the implications of health and nutrition at early stages of life, its relations both with the determinants and the consequences that the inadequate or a bad nutrition may have during the life course, so that we can analyze the results, the evidence available, while considering the challenges in terms of health and well-being of newborns and their families in the Americas that we want to approach from an equity and rights perspective. So without further ado, I'd like to give the floor to the speakers with whom we're going to share this seminar. So now we introduce the speakers of this session. With us today, we have Dr. Audrey Morris, who's an advisor on nutrition Food and Nutrition in the Department of Non-Communicable Diseases and Mental Health of the Pan American Health Organization. Dr. Audrey Morris will talk about breastfeeding and early nutrition and the correct and nutrition right start. Now, so then Dr. João Abrigio, coordinator of the Brazilian network of a human milk bank of the Osvaldo Cruz Foundation, and we are going to introduce this center as a collaborator, as a partner of the Pan American Health Organization, working with us to strengthen human milk banks in the region. So this is a partner that was recently appointed as a collaborating center, and they have a long history, but from now on in coordination with PAHO and WHO. And finally, in my case, I'm going to talk about nutrition at early stages of life and its challenges with an equity perspectives, right, and rights perspective. So now let me give the floor to Dr. Morris, who will be the first speaker. Thank you. Dr. Morris, you have the floor.
Good morning, everyone. Good morning. Can you see my presentation? And can you hear me well? Good morning. I just want to check if you can see the presentation and you can hear me.
Sí, perfecto.
Gracias.
Gracias.
Okay, thank you so much. And thank you very much for this invitation. And in this presentation, I am going to tell you about starting out right, what's the current situation, the barriers and missed opportunities that we come across, how can we clear the path for breastfeeding. I'll also talk about the care of small, sick, and preterm infants, and also some lessons from countries who have been successful. Now, Smith et al. Did a systematic review and meta-analysis in relation to delayed breastfeeding initiation and infant survival. And their review included meta-analysis of 5 studies from 4 countries and more than 130,000 breastfed newborns. They found that newborns were breastfed 2 to 23 hours after birth had 1.3 times more risk of dying than those who were breastfed within 1 hour of birth. Additionally, newborns who were breastfed 24 hours or more after birth had more than twice the risk of dying in relation to those who were breastfed within an hour of birth. And the protective effect of early breastfeeding was independent of exclusive breastfeeding. The authors also highlighted the fact that a study in Tanzania found a higher risk of respiratory infections with late initiation of breastfeeding. What's the current situation? The global databases of UNICEF from 2018 reported that about 78 million newborns had to wait more than 1 hour to be put to the breast. And the percentage of newborns put to the breast within 1 hour was 42% globally. And there was a variation between a low of 32% for East Asia and the Pacific and 65% for Eastern and Southern Africa. But the percentage in Latin America and the Caribbean was 52%. And the map that you see there shows in color the situation in the different countries in the region, with the green corresponding to 60 to 79% for some of the countries in the Americas. An analysis of barriers and missed opportunities for practicing early initiation of breastfeeding found that the main issues are outdated practices in health facilities, that is mother and infant separation, a lack of knowledge on breastfeeding post-cesarean section, and cultural practices that result in feeding babies other fluids or foods rather than breast milk. And there's also the fact that skilled birth attendants are not appropriately trained in breastfeeding. The graphic that you see reflects the fact that early initiation rates have only improved significantly among the group of countries that had a large increase in institutional deliveries. This graphic shows that in nearly every country, early initiation rates are significantly lower among newborns delivered by C-section. The clear dots, those more to the left, reflect cases with C-section, and the darker ones, those with vaginal deliveries. So you can see and appreciate the differences there. And then this graphic shows the effect of cultural practices, where early initiation rates are nearly twice as high among newborns who receive only breast milk, compared with newborns who receive milk-based supplemental feeds in the first 3 days of life. The green corresponds to newborns receiving breast milk only and are the highest percentage of early initiation. And then the blue corresponds to use of non-milk-based liquids. And then the pink is milk-based supplements, and that's formula and animal milk. And this was the lowest percentage of early initiation. So the baby-friendly hospital initiative is key to clearing the path for breastfeeding. Perez Escamilla et al. Made a systematic review about the impact of BFHI on breastfeeding and child health. And that systematic review included 19 countries. They found that the adherence to the 10 steps to successful breastfeeding in maternity facilities can increase breastfeeding rates, including early initiation of breastfeeding. They indicate that, Breireshwa et al. Carried out another systematic review about interventions to improve breastfeeding. And this review included program and policy-related factors. And they concluded that a combination of interventions had the greatest impact on the early initiation of breastfeeding, leading to a significant 85% increase in rates. They indicate that to promote breastfeeding optimally in an expectant or nursing mother, support should be provided throughout the continuum in multiple settings, such as increasing community awareness regarding breastfeeding, followed by hospital or health system support through the BFHI approach, and home and family support through counseling. Counseling by peers or health personnel and baby-friendly hospital support and community mobilization are the key interventions to promote optimal breastfeeding practices. So they recommend a multidimensional approach to strengthen breastfeeding interventions. They also indicate that a strong political will, advocacy, and championship by health ministries at the national and subnational level, ongoing monitoring and evaluation are needed to meet the global targets of the Comprehensive Implementation Plan for Maternal, Infant, and Young Child Nutrition. Moving on now to care of the small, sick, and preterm infant. WHO and UNICEF released in 2020 a publication about the BFHI for small, sick, and preterm infants. Now, it's well known that these babies are at an increased risk of early growth retardation, infectious disease, developmental delay, and death during infancy and childhood. So human milk and breastfeeding are extremely important to reduce morbidity and mortality and support the best growth, development, and overall outcome for these babies. The current WHO guidelines and implementation guidance state that all infants, including small, sick, or preterm infants, should be fed human milk. And if the mother's own milk is unavailable or contraindicated, safe donor human milk from a human milk bank will be the feeding of choice for these infants. The publication by WHO and UNICEF indicates that systematic reviews have demonstrated the importance of professional and peer support, skin-to-skin care and rooming in, counseling and support to initiate and maintain milk supply, as well as the provision of oropharyngeal colostrum early, and also the use of donor human milk banks. To finalize, I'm going to share lessons from different countries to help babies get a good start. In Cambodia, there have been awareness raising and promotional campaigns that had resulted in an increase in the rates of early initiation of breastfeeding from 6% in 1998 to 63% in 2014. They were also able to have an increase of deliveries attended by skilled birth attendants from 44% in 2005 to 89% in 2014, and an increase in institutional deliveries from 22% to 83%. And additionally, the use of supplements or supplemental feeding in the first 3 days after birth decreased at all levels of care between 2000 and 2010. From our own region in the Dominican Republic, they had an increase of C-section rates from 31% in 2002 to 58% in 2014. And during this time, the rate of early initiation of breastfeeding decreased from 62% to 38%. To modify this trend, since 2014, the Ministry of Health and partners have increased support for the Mothers and Newborns in Good Care initiative. And this initiative integrates the promotion, protection, and support of breastfeeding. Monitoring BFHI standards and the code remains a challenge in the country, particularly in private facilities, where 40% of deliveries in general and 86% of deliveries by C-section take place. So we do acknowledge that there are challenges, but considering all that I've shared with you, we make the following recommendations. Ensure the right start for all infants, fully implement the International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly resolutions that really interfere with breastfeeding. Enhance the quality of care in facilities. So there should be immediate skin-to-skin contact, early initiation of breastfeeding, other evidence-based recommendations, which really lead to the 10 steps to successful breastfeeding. All of this to enhance the quality of care in facilities. Apply the 10 steps in the case of small, sick, and preterm infants, and improve access to skilled breastfeeding counseling for all mothers. There also should be a strengthening of links between health facilities and communities, and encourage community networks that protect, promote, and support breastfeeding. Thank you for the opportunity to present, and I want to acknowledge the assistance of Dr. Carmen Casanovas for this presentation. Thank you.
Muchas gracias,
Thank
doctora.
you, Dr. Morris. An excellent presentation, extremely clear, concise, and highlighting the main aspects regarding breastfeeding and the timely onset, early onset of appropriate nutrition in the life course. Next, I will hand the floor, as stated, to Dr. João Aprecio, who will speak on human milk banks and sustainable development in the Americas region, a strategy for food and nutritional safety. The floor is yours. Good morning. Have a good day, everybody. Dear friends, it's a pleasure, a great pleasure for me to be here with you, representing our collaborative centers in the Brazilian network for human milk. This is a major collective construction that has been working in Brazil, and we want to be spread throughout the region. I will put my presentation on screen. The topic I will discuss is the human milk banks networks. This is a very important strategy for food safety for newborns and infants, particularly in the Americas region. I would then like to tell everybody about the different movements we will discuss. We will start with the first item. Who are we? What are our goals? And the second movement, very briefly show the genesis and evolution of the human milk bank networks and where we have reached and where we're planning to go, how we plan vis-a-vis the 2030 agenda, and how we move in relation to monitoring and evaluation and in planning. Who are we? This human milk bank network. We are a strategy for nutritional and food safety. It's part of the public policies in public health. And why can we state in a categorical way that we are a food and nutritional safety strategy? Because we work in a way that is really geared to the two major issues regarding food safety, and that is a guarantee for quality and access. And what is important here is that usually when discussing food safety, this is always correct when we refer to the introduction of supplementary foods. But there's a vacuum when we're discussing neonatal care. There's a vacuum in that context, and that is where we begin to work. What is food safety? I will summarize this. This is an image that is in the center of my slide. On the one side, we have where we're collecting milk. This is a symbol summarizing our work, our human milk banks in Brazil, in Latin America, the Caribbean, and even in Portuguese-speaking Africa and in the Iberian Peninsula. We support feeding, and we conduct our work observing two major axes to
major macro processes. First, all the work in the outpatient clinics conduct maternal assessment and counseling for feeding. This is all based on breastfeeding, because our major goal is not to collect and distribute milk. Our major goal is to promote breastfeeding in a safe manner, supporting breastfeeding in a safe manner, particularly with a challenge, and that is the follow-up in the third level of care. We promote, protect, and support breastfeeding in the third level of care. Therefore, our professionals that have worked hard are well trained to conduct all this counseling for feeding and marketing of food supplements and breast milk supplements. And we also need human milk as a safeguard for life, particularly for small newborns, prematures, and low birth babies, those that for different reasons have difficulties to receive milk directly from the breast. And thus, we need a set of standards and procedures that are adapted to food technology to allow this human food that ultimately is much more than a food. It's a medication, a biological medication, in summary, a functional food. And for it to ultimately comply with its therapeutic role as a therapeutic resource. In summary, this image is what we do, focusing on many tiny things with our small newborns that are clients, be they premature, low weight, and cared for at our unit or units of neonatology, working with the human milk bank networks so that the mother can rescue the breastfeeding and produce milk for it. And ultimately, throughout the period, all the feeding was ensured through human milk with a quality certified by our human milk bank network. And the second time, to have a kangaroo system that is a focus of our care activity, reaching to the child receiving milk so that they can be included in the most challenging phase of the human milk bank network, and that is to seek an interrelationship between our action in the third level of care and what will occur in the future in basic care. That is a major challenge we're working on currently, to extend our capability of caring for maternal breastfeeding,
to improve maternal breastfeeding, ensuring an interface with basic nutrition. So for me, this slide for me is very emblematic, and it highlights the role that we play in the region, not just in the Americas, but also in all the countries, including in Africa, where we have colleagues that are participating in this seminar. And even here, we want to highlight the number of donors within the Center of Women that receive care for breastfeeding at the labs of our human milk network. So for this is a matter of pride, because when we compare the ratio of women that receive care and the women that actually donate in the network, we have an 11% ratio, and that is very high, and that shows that our aim is the support and the protection of breastfeeding as champions. So any women presenting any difficulties or with the problems to breastfeed can look for us, not only to donate milk, but also to receive the assistance of the colleagues there that are very well trained. Look at the ratio between the numbers. 17,860,678 women that receive care. So that's quite a lot. It's almost 18 million small newborns that have a chance to receive human milk of their mothers, thanks to the direct assistance of our human milk bank network. This other slide is also very emblematic. When I mentioned as I mentioned initially, we are compulsive in monitoring and evaluation. When we started with the work building our Latin American network, well, it turned into an Afro-American with our groups, the groups that joined us, and then we decided what is the projection of the coverage in Latin America, and it was more than 16 million newborns up to 2020. Sorry, it's 1.16 million. And you see that in 2016, we had already achieved 1,881,212 newborns that benefited from this initiative that was much higher than the 1.5 million that we had initially planned. So there's a very quick improvement of the numbers. In 2005, when we had our first global meeting to discuss the creation of a human milk network, there were no such banks. So we had them in Brazil, but they were not present in many countries, and that happened in Brazil thanks to the research and development of our foundation and the Ministry of Health. So we could develop that model for the human milk banks and homes for infants, and models of human milk banks for Latin America. And that shows the character of our work. So you see that from 2005 and 2016, there were no such banks in Guatemala, and now in 2016, there were 11. I won't give you all the figures, but it is very clear, and I invite you to visit our website to get to know the evolution more clearly, and to see what our history was. This is a work that went beyond borders, beyond South America. We also included the Spanish Caribbean and Central America, and then Mozambique and Angola, and Spain and Portugal also implemented those initiatives. And this network grew, and it works in an absolute collaboration. To speak of the genesis of the bank or the way we work, I'd like to be quick here, because I want to share with you a 5-minute video that may be the best way that we can show you the results of our work. But it's this: 3 decades of investment in R&D and technology, in partnership with technological developments. And then in 2001, WHO recognized the positive impact of the network in Brazil. It was the work that most contributed to child health in the 90s. And in 2001, they acknowledged that there was a very high increase of international visibility, and PAHO played a key role. And the Brazilian Agency of And the Fiocruz Foundation included this in its agenda. The foundation worked endless work for this network, and we have a very good relationship with the government, and based on those good levels, our idea is to reach the professionals. So that is a movement that was created like that because of the concern that we had to reach sustainability. We need to be sustainable from the technical standpoint, and we need to do it in order to do that, we need to be financially and politically sustainable. So always preserving the cross-sectional principles, everything that you know that is absolutely necessary, respecting sovereignty and without putting any conditions, and evaluating also seeing the worth of the different initiatives. So we started in 2005, and until then, we had been carefully monitoring what the WHO and PAHO were discussing about the SDGs, the indicators, the goals and the targets, and the multilateral articulation. So first of all, with the 2020 Brazilian Charter, then we had we met in Montevideo in 2014. We strengthened that commitment, and in 2015 we had the Brazilian Charter, making adjustments that would enable us to migrate for the SDGs. And there you have the Brazilian Charter, and there we repeated our commitment with the countries, and there we had 35 signatures of official representatives of PAHO countries that always work with us, and also the rest of the actors in society that work in areas related to breastfeeding. And we identified what we needed to do to, especially to raise awareness to SDGs, especially SDG 17 and SDG 3. So SDG 3, ensuring healthy life and promoting the well-being for all at all ages, and 17, strengthening the mechanisms for implementation and revitalization of the Global Alliance for Sustainable Development. So this is the way we started. Initially, we had a good beginning, and we always tell the collaborators, and we always thank PAHO for the great support that they give to the Brazilian network, but also the global network of human milk banks, the networks in Uruguay and Argentina and Mozambique, a huge number of networks that I won't mention because of lack of time, but it's huge. And having shared this with you, it's very important to see how to monitor and evaluate what we do. How can we conduct an assessment of our planning? How can I monitor it? So we chose an element that is important for mediation between the SDGs, the document, and we had the Brazilian Charter with all of the commitments that were agreed upon with the countries, where we committed ourselves to implement, to articulate a system to achieve those SDGs. And so we established a dialogue between with the countries to coordinate the work for those two SDGs. I won't give you the detail of everything that I included here, but this is just to give you an overview of the activities done and what we do for each goal to show our cooperation, the two SDGs and the specific targets. In the case of SDG 3, the commitment with targets 3.2 and 3.4. That's why we are food and nutrition security strategy, because our commitment is not just with newborns. Promoting breastfeeding is not our only aim, but also to monitor the children, preventing the non-communicable diseases, mental health, and well-being and its relation with breastfeeding. So our commitment goes far beyond the neonatal period. Well, of course, that is what we are aiming at essentially, but SDG 17 is also plays a key role. So it's thanks to the global alliances for sustainable development. We work with governments too, and with different stakeholders. We could go more in depth here, but we wouldn't have been able to move forward as much as we did if we hadn't had those partnerships. Here we have a list of each and all the components. We established the relations that are represented here as a summary in this chart. And based on that, we build a dialogue, and based on the charter and our monitoring matrix. Each one of these elements, we work with what's happening with the products and processes.
Nós então instituímos a criação do nosso
we create the global network of banks, and an example of that is here you have a summary, is an observatory that where we describe the operational problems that we had. And we because of budget problems, we had an interruption, and now we are resuming that work. And the countries, it is important here to speak of each of these goals. There you see what we did in 2017. We always try to aim at different segments. So, and we work with that perspective, building the Ibero-American network of human milk, and we also worked with each of the countries.
Também a discussão com os países que integram.
We reached a discussion with the countries in Mercosur, Brazil, and countries such as Argentina, Uruguay, Paraguay. Oftentimes, crossing the street, we're crossing the border. So it's very important for us to have this possibility of considering the same health umbrella in terms of regulations and laws, because they become transnational and cross borders. So this initiative occurred, and as I mentioned more recently, the creation of the Human Milk Bank Network. In India, China, we had a first workshop. Unfortunately, it didn't work as fast as we wished due to the pandemic and other issues, but it is ongoing. We have a collaborative center between PAHO that is working together with WHO, and starting from SDG 17, we have this partnership to join efforts to reach all the commitments we gave examples of very briefly that are included in SDG 17. The goals 3.2 and 3.4 based on indicators. I will end stating to all that this exercise was of vital importance. This was fundamental because thanks to these joint efforts and the cooperation and everything we conducted in our health systems in our countries in a joint manner, we managed to work together, and this allowed us to overcome a set of barriers that have been imposed by the pandemic, and this has allowed us to continue with the working process and functioning of our human milk banks, generating safe solutions so that the supply of milk could continue and our newborns continue being born in the best way. Well, I want the organizers to tell me if I can use 5 minutes more to speak about this process. It's the first time in history that we have conducted a partnership that is truly global. We had the participation of over 50 countries to defend this slogan to mobilize a World Day for human breastfeeding. And this was voted openly in the internet. It was done in a very collective manner, that countries had this chance of discussing this and reach criteria in an open and transparent and democratic manner. The slogan chosen was, as stated, World Human Milk Donation Day, and a hope that has been born. We have all these countries participating as listed. If you are aware of history, you know about this, but this is translated in what we have in these figures here. We had 47 countries participating with 298 slogans written to reach the one we presented, and a set of 3,394 votes from different regions in the world. Excuse me. He said in the countries, not the world. Well, we're very proud about this movement, and this is duly registered in this book from the International Cooperation Forum for the World Day for Breastfeeding, lessons learned during the pandemic of COVID-19. What more can we do? So this material has been published in Portuguese, English, and Spanish. It's a video book, and the work conducted in all the countries of the global network is included experiences of service, academic discussions, work such as those presented by Victor, present here, of trends for feeding in the current world, experiences with newborns and feeding, donation of human milk in countries that were more advanced, such as Israel, England. Well, this material is excellent, so I recommend that you take a look at it and enjoy it. Please. If you allow me 5 minutes more, I don't want to abuse of the hospitality of the organizers. I would like to share a video that is the first important word of the collaborating centers. If not, I will leave you the link so you can look at it yourselves. Thank you then. Please let me know. If we can see the video. Yes, Xiao, maybe in a couple of minutes. So we hear the next presentation first. Yes, it's okay. Thank you very much.
Soy donante de leche humana porque me interesa.
I'm a human milk donor because I want to contribute to donations. Donating human milk allows me to provide health resources and quality of life for those who are just starting their life in this world. Being a maternal milk donor is important in the pandemic because with my milk, I provide better tools and possibilities for a better quality of life. The human milk banks are very important during the pandemic. Some donors are providing milk to the banks so that we can collect milk, but we shouldn't stop doing it so that we can donate milk for those who require it according to the different recommendations. The truth is that this is the best act of love and solidarity and empathy. We are an excellent team, my husband and I, and the physicians and the nurses in the workplaces. This is a true network and a true team, and it's beautiful to be part of it. Well, when you ask me why do you donate human milk, the answer is because if the body allows, well, why not? Your body is producing something that you can contribute with. It's easy, it's not very hard work, and it really helps in a great manner, making a better start for the infants that need it. So here, as elsewhere, everything you can do is welcome. My experience has been very good, and I recommend people to do it. The physician said, bring your milk, press your milk, and I left. And it was very difficult to press milk. Very little was obtained. I had very little milk. So the physician said, don't worry, we have this milk bank. There are mothers that donate milk. So I felt much better, really, because it was an issue. Because my baby was receiving a lot of medication, but also needed to be well fed. Well, this helped me to understand this issue of what families are, to place myself in a different place together with my husband, and helped me also to save babies and to think every day on the smile and the joy of these mothers receiving that milk. Well, I always imagine saving families, but also the future. And well, maybe, who knows, maybe this will be part of my family, a friend of my sons or daughters. They will become professionals, and I know that this has made a difference. And this small action is transformative. and impacts in a major way, transforming lives. And this is really a wonderful, doing these very tiny things, impact on a life, on a history. So I'm very happy about it. The network of human milk banks is an expression of solidarity, an area for exchange of knowledge that saves lives of babies every day. And it's always important to recall that breastfeeding isn't a simple issue. That is why the success of breastfeeding isn't only the responsibility of the mother, but of all, the community, employees, families, governments, health professionals, the media, all of us. At present, the association between the Human Milk Bank Network and PAHO is strong. Donating milk was always safe and will continue being safe even during the pandemic. PAHO continues recommending breastfeeding as the best and safest food for our babies. Those who donate save lives, and supporting donation is our responsibility.
Muchas gracias.
Thank you.
Excelente, muchas gracias, doctora Prillo. Excelente la
Thank you, Dr. Prillo. A wonderful presentation. Both presentations were the importance of breastfeeding and donation and facilitating a timely early access to human milk is essential. In that sense, we will now hand the floor to our last speaker. Well, that is myself, where we will try to summarize the different ideas, aspects, and recommendations that both Dr. Audrey Morris as Dr. João Aprígio have highlighted. Well, we want to basically share from the point of view of CLAP and of health and nutrition during the early stages of life from the standpoint of equity and rights. What is the current situation and the challenges awaiting us? This seminar is somehow responding to two clear goals. One, in the framework of the month devoted to strengthening and working for breastfeeding, and the second, precisely in the framework of providing guidelines and recommendations and technical cooperation to countries regarding perinatal issues. We have started at the beginning of the year work together with different areas and units in PAH.
Nutrición, como mencionamos previamente.
With the nutrition unit, as was mentioned earlier, the Department of Evidence and Intelligence for Health, based on the recommendations and the evidence available. And also, I'd like to thank Dr. Alejandro Dinerstein, with whom we are consolidating the evidence. And as I said earlier, the elements related with health and nutrition are included in the strategies and mandates and the action plans that are included in the SDGs, especially SDG 2 and SDG 3, but in the framework of the 17 objectives, goals that provide a comprehensive perspective with the interrelationship between the determinants and the achievements of results that are essential. So in the newborns, there are as many targets as specific goals. And you see that the idea is to put an end to all ways of malnutrition and to meet the needs of adolescents, women, pregnant women, infants, and the elderly. And in the case of health, to put an end to the avoidable deaths of newborns and children under 5. And focusing on the newborns, both the global strategy of the child, the health of newborns, child and adolescents, they establish goals in that direction. So in the framework of the reduction of inequalities and preventable deaths, we have included the goals also related with the reduction of low birth weights, because in addition to the comprehensive nature of the actions that are implemented to contribute to the exercise of rights and achieving health and development, we need to approach this in the course of life and with nutrition in adolescence and in adult age, especially in the pregnant women and in the immediate perinatal period, but of course all along the life course, because that enables you to get very good results. But on the other hand, we see in dark red how the maternal and neonatal conditions in dark red, especially the right part of the chart in countries with a low degree of development, these are the ones that contribute in a significant to a significant extent in the burden of disability and morbidity. So paying attention to these aspects of nutrition, not only does it have an effect on health, but also in addressing inequalities, because it's the most vulnerable that suffer more of this. And here I wish to tell you of an article that, although it is not recent, it's absolutely valid today. So this analysis that was based on a number of populations analyzed the impact of acute malnutrition and mortality, and from a linear point of view, we saw that only with a moderate to severe malnutrition did we have an impact on mortality. However, when instead of considering malnutrition yes or no, but we added some things and we assessed it from the point of view of worsening and changing this into a logarithmic. Pablo, you're not sharing your screen.
Ahora sí.
Gracias.
No, yes.
Como les decía,
so as I was telling you, when the data were transformed into a log scale, what we could see was that the impact of the nutritional impact is not just seen in the extremes, but throughout the continuum. And that is why it is important to consider the effect of nutrition as a continuous effect. And what is the relationship between the perinatal outcomes and nutrition? Well, the WHO, together with a number of researchers and experts, presented in early 2021 a new series in the Lancet on mother and child nutrition and the progress made. This paper that I'd like to discuss, to discuss some elements here, shows that the improvements in terms of the deleterious effect on the linear growth of children under 5 have shown little improvements, small improvements in linear growth. There is no progress for wasting and low birth weight, but it shows how important it is to consider the perinatal period and the first 6 months of life, or the 1,000-day concept as the key to strengthen nutrition-related interventions, and especially in the context where the inequalities are important. And we know that the region of the Americas show are key determinants in malnutrition in women and newborns. In this case, low birth weight, we know that it is not the best indicator from the conceptual point of view, but it is important in terms of how easy it is to obtain it. Shows an association both with elevated risk of child mortality, stunting, and developmental delays, as well as adult onset metabolic diseases. And the low birth weight indicator, as I said, although it might not be the best, because we know that it encompasses 2 key conditions. One of them is being born premature, and the other is the intrauterine growth retardation, that is the SGAs. And we see that in Latin America, almost 9% of the newborns are premature, over 12% are small for gestational age, and a lot of them, 10%, are full-term newborns. So even when they're born full-term, they have an impairment of their intrauterine growth that puts them at risk. We are speaking of almost 1 million premature babies and almost 1.5 million newborns that are small for gestational age. And if we relate that with what Dr. Morris presented, showing the inadequate compliance with an early and timely initiation of breastfeeding, you see that in the Americas, 1 out of 2 newborns do not start breastfeeding within the first hour. So this shows how important it is to have a comprehensive approach to this. And we've already mentioned the baby-friendly hospital initiative, especially for the small and severely ill newborns. And this should be seen with the components of nurturing care, that is good health, adequate nutrition, responsive caregiving, security and safety, and opportunities for early learning. So here, it is important to consider the guidelines for monitoring the newborns at risk that we have developed at CLAP and PAHO, that gives us a comprehensive view of 3 moments that I'd like to discuss. One of them is the pre-service and in-service care. And here we know, and I reinforce something that we mentioned already, that is that we need to provide appropriate care. And in order to do that, it is essential and to follow the 10 steps in the baby-friendly hospitals initiative, to have programs, knowledge, skills, and competences for the entire healthcare team that should be updated and be provided regularly so that all the staff may know and to know this, to promote the 10 steps with a perspective of multidisciplinarity and with an active engagement of the groups of mothers and caregivers that may strengthen compliance, and with a permanent competency assessment so that they may be sustained. Now, together with the strengthening of the healthcare team, the availability of evidence, and today essentially in the perinatal period, we know that delaying the umbilical cord clamping beyond 1 minute and up to 5 minutes enables us to favor the access to an intervention that has been with efficacy, of which the efficacy has been proven, not just from a nutritional point of view, but also from the point of view of survival. And even in the premature, it's a safer intervention. Early skin-to-skin contact and the support for breastfeeding initiation within 1 hour of birth. These are the 3 essential interventions in the early moments around birth. But this also implies that the healthcare teams must be responsive to the specific needs, essentially, of the premature newborns and severely ill newborns and the small and sick newborns. So mothers, fathers, family, caregivers must be actively involved in the process. They need to be able to detect the signals that lead to promoting breastfeeding, especially in the small and sick newborns. Depending on their gestational age, these newborns may not exhibit any feeding cues in the first weeks of life, so everybody has to be paying close attention so that mothers and caregivers should be aware of that and get involved. The feeding of human milk should be started as soon as the infant is deemed stable in the case of newborns that are born sick. But essentially, as was already mentioned by Dr. Aprigia, by promoting the strategies that, given the lack of possibilities for maternal breastfeeding, the access to human milk is essential, and not just breastfeeding as a nutritional strategy, but also in the frame with a rights-based perspective. We must consider this among the measures of care that don't have to be with nutrition, but that will, especially in newborns that need special procedures. It's important to highlight that there's no need to evaluate other alternatives that are not human milk when you have premature babies, except for very special situations. And this other aspect that we received a question in the chat as to the best method for the transition in the cases where we need other nutrition modalities.
Because at present there is no specific consensus, and it's important to contribute to evidence and adapt strategies and actions for each particular case. The second central issue I wish to highlight, well, care during hospitalization is essential, but it's during discharge, particularly in newborns that are in the ICU, that is very important. Newborns with specific needs requiring referral following discharge to interdisciplinary teams, be it in clinics or different groups providing this care. Another issue that was also discussed during the chat is kangaroo maternal care. This isn't only during discharge. We must promote, support, and implement the kangaroo mother care in the neonatal care units and support it following discharge. There was an excellent paper published by a colleague from WHO proving the important impact of kangaroo mother care on survival, even in newborns between 1,000 and 1,800 grams. Of course, counseling and family education regarding nutrition with human milk and feeding during discharge are essential. And in terms of equity, it's very important that particularly in peri-urban, rural, social and economic contexts, when they return home, we need the health team and system provide appropriate care. Guidelines for follow-up of newborns at risk provide criteria for discharge, the different issues to be strengthened, skin-to-skin care, kangaroo mother care, followed by multidisciplinary teams, appropriate screening, be it for the possibility of anemia and other supplements required by infants. Stabilization of weight gain and its follow-up are essential. And it's therefore very important to take into account the different mechanisms for hospital discharge so that all this is strengthened and so that the information be provided to the families and caregivers. And once again, strengthening this need for skin-to-skin contact, exclusive breastfeeding, nutritional requirements, particularly in newborns with a short intestine and other special conditions that will not only require follow-up, but a very specific response, and also warning signs and other aspects for kangaroo mother care, adherence to the different home visit programs by the community health teams in areas where this is implemented. All this is very essential. So the establishment of different programs for high-risk neonates are extremely important, both at service level and in the health system and at ministerial level in the countries and different areas, establishing different agendas and timelines in a comprehensive way where the different moments and different clinical checkups of nutritional condition, neural development, hearing health, visual health, anemia, and so on, be included and supported beyond hospital discharge. We are aware that health and nutrition require intersectoral, multidisciplinary interventions where both the health system and the nutritional system and sectors providing social support and others are very essential to achieve this throughout and not only in a specific moment. So at operational level, we need to approach the challenges for implementation at regional, national, and institutional level that have been set, because the policymakers, managers, researchers, academia, families, and caregivers are essential, each in their own milieu, to contribute to formulate policies, develop protocols for training, implementation, surveillance, and active participation of all players. And this requires specificities, both in terms of healthy newborns and the specificities of small and sick newborns, as mentioned, issues regarding the time of discharge, follow-up, and more specifically, specific needs regarding emergency settings. In Tahoe and CLAP, we promote breastfeeding, an excellent example of how at different levels with the 10 steps in the baby-friendly hospital initiative, we promote the decision makers and the health teams and families, and with the surveillance with the perinatal information system, allowing to have indicators that indicate health and nutrition during follow-up, will allow us to advance in the roadmap, strengthen policies, and more especially generate the evidence we need. And the group mentioned is very interested in working to strengthen and extend the evidence for specific care in all newborns, and more particularly in those that are small and severely ill. Parting from this evidence, we will develop protocols and guidelines, and many countries in the region are focused on this need to provide appropriate newborn care in this manner, leading to implementation, monitoring, and appropriate evaluation. This then is a call and a proposal and invitation, so that in the different ambits where each of you present works, approach this to respond to these challenges that, I repeat, at operational and implementation level require further approaches. Thank you for your attention and for allowing me to participate, and in this manner I end my presentation. We're close to the end of our meeting, and we hope this has been useful to you, and to have it renew the commitment of all participants on the subject. Now, I will use an extra minute to request Dr. Audrey Morris and then Dr. João Aprígio to first summarize in 1 minute, in one sentence, an idea you could leave us as a take-home message. There are many questions. You'll receive the presentations and the video. We have had questions about HIV and safety with in bank milk. Well, now, without further ado, Dr. Audrey, if you want to use your minute for your take-home message. Thank you.
Yes, thank you so much for that opportunity. And I noticed there were a couple of questions about the international code. And in my presentation, I also mentioned the baby-friendly hospital initiative, as you did. And it is important that we implement these. These are some of the best tools that we have to ensure that children get the right start in life. The BFHI, in the case of the maternity facility, implementing the 10 steps, and the international code in preventing the indiscriminate marketing of breast milk substitutes, so that these substitutes and these companies are not allowed to discourage women from breastfeeding and does not feed them with false information. So that's what I want to leave you with, to use the tools that have been provided by WHO in order to strengthen breastfeeding, strengthen early nutrition in the best start to life. Thanks.
Thank you, Dr. Morris. João, the floor is yours. You have your minute for your take-home message. He can't open his video camera. The truth. Well, Thank you. I am very grateful for this opportunity to be together with you, sharing all these ideas with you. And I also thank you for all I learned with Dr. Audrey and Dr. Pablo. And my take-home message is that we must continue working in the same direction, strengthening the integration of our lessons learned to strengthen our union in countries in terms of human milk monks with the support of PAHO. And ultimately, we have this commitment of extending this area of knowledge exchange, be it scientific, technological, and cultural, regarding issues related with breastfeeding. I believe that this extension and exchange of knowledge are decisive so that we can really achieve what we have committed ourselves to work towards, to improve the quality of health in our populations. Thank you all. Thank you, Joao. So now, before closing, two final comments. You will all receive, as we said, the recording and the presentations, and we will answer all the questions made during the event when this has not already been the case. So once again, thank you all for participating, for your commitment, and on behalf of PAHO and the Family Health Promotion and Life Course Department and the Latin American Perinatology Center and Women's and Reproductive Health, Dr. Seruja, and all the team participating. Thank you all, and the speakers and the whole team for communications, platform support, and interpretation, allowing us then to host this seminar and meet our goals, be it in terms of the topics and the time required. So thank you all. Have a good day.
Muchas gracias a todos. Veo que aún está João y otros, a las traductoras, a Ana, a Pablo. Un éxito total, ¿no? Más de 500 personas aquí en Zoom y no vi los YouTube. Felicitaciones a todos. Nos vemos pronto. Pablo, muy bien. Excelentes exposiciones de todo. João estreó, como decimos en portugués, de manera brillante. Muchas gracias a todos y ahora me desconecto. Chao, chao. No te escuchamos, Pablo. Abrí tu micrófono.
Sí, no sé si está abierto, pero gracias.
Suzane, muito
Susana,
obrigado.
gracias.
Pablo, muito obrigado.
Muchas gracias.
Muito obrigado, Suzana. Muito obrigado, Pablo. Muito graças pela oportunidade. Muito obrigado a todas e a todos.
Muy bien.
A ustedes. Chao, chao, João.
Chao.
Muito obrigada. Foi maravilhoso. Bye, bye.
Um abraço, tchau.
Gracias.